Now I can hear him.
Maybe this will work.
That works great. And Anthony, I think I worked out a problem that was perhaps on my end in the first place. If you can still hear me, hopefully you can call back in and rejoin us. My apologies. So, welcome, Jan. How are you doing?
I'm doing good. This kind of reminds me of the electronic health record.
Yeah.
Sorry about that.
A work in progress, I suppose, and hopefully things are better. Well, I guess we're working here now. Hopefully the electronic health record can be fixed just as easily. Though
I doubt it.
I fear not. Yeah. Well, as I was sort of bumbling through the technical issues here, I started talking about the DNA sequencing post that kicked off this edition of Health Wonk Review, and I wonder if you had any thoughts about that, about sort of how far we are from sort of gaining usable or gleaning usable information from a full genome sequencing in terms of individual precision medicine efforts. You think that's pretty far away at this point, or not close?
Personally, I read that post. It was quite interesting. On the other hand, the Human Genome Project is sort of reminding me personally as the adage, I think I've heard it described about the adage that describes Brazil. Always the country of the future. It could turn out that the Human Genome Project will continue to be will forever be condemned to being the technology of the future. How close we are to being able to take human genome information and actually make it actionable at the usual retail medical level remains to be seen. There's some interesting stuff going on in cancer care, tailoring therapies in the world of cancer care. But how well that translates to me as a doc being better able to treat persons with high blood pressure, diabetes.
The hope is that through a tremendous volume of these sorts of records, there may be the ability to develop some precision medicine applications through the use of machine learning, et cetera.
Precisely, and we're at that point in the information age where Moore's law and the doubling of information capacity and processing power. I mean, if you think about our ability to double processing power and the amount of insight that will go along with that, with the information that we have now, there are some potentially very spooky, interesting things that we'll be able to do in the not too distant future. So stay
Anthony,
tuned.
you're back. Can we hear you? Can you hear us?
Testing. Can you hear me?
Yeah.
Yes.
Oh, good.
Excellent. Sorry for the technical difficulties earlier, and I'm glad you're able to join us today. Welcome.
Great to be here.
So, I was starting to move on into Joe's post about the Clinton health plan, and wondering if either of you had some thoughts. I've spoken before about the idea for Medicaid expansion there, and sort of the problems that I think we may encounter, and opposition at the state level. I'm wondering if either of you had any other particular points, particular thoughts, reactions to Clinton's plans.
I think clearly.
Unfortunately, David, I'm at a disadvantage.
Okay.
I can't hear.
Can you hear me now?
Still no?
No. So
there you go.
Can hear me, but not John? Okay.
Clicking away.
Well, I can hear both of you.
I'm getting some kind
I'm
of
hoping
firewall
that people can
message.
hear me when I will say.
I'm a big fan of Anthony's, and I can pretty much predict not predict, but I'm pretty confident on where Anthony falls on the when it comes to
Great.
uh,
So,
health
Jan,
reform
we'll listen to
and
Anthony, and
support for the
hopefully you'll
Clinton
hear him
plan.
at some point. Go for it, Anthony.
Yeah, so I think it was
I'll
interesting to
work on it.
see the secretary's what she plans to do with health reform, especially given her past history with health reform. She came out early with a number of proposals. It she has a even for a presidential campaign, she has a level of wonkery and detail that is um, in large contrast. Would be in large contrast to a normal presidential candidate, is even a greater rift with the current Republican presumptive nominee. Um, but I do think that she is working on a what are ways that we can implement and improve upon the Affordable Care Act through making sure that there is that the states that can that there's the incentives in place to take up the Medicaid expansion, but also to do some additional efforts with regard to additional efforts around affordability, additional efforts at cost control, especially in the area of prescription drugs, and additional areas with regard to some further reforms. Not big wholesale changes, but step-by-step improvements on the base of the Affordable Care Act. And that was part of the debate that she had with Senator Sanders, who wanted a much more broad rethinking of the health system.
Right. So if we can skip around a bit here, within the context of what has been in place to date, one of those is the availability of a series of waivers. And you wrote past week, Anthony, about California legislative effort that has now succeeded at the legislative stage to pursue such a waiver. So I wonder if you could describe that waiver program and the waiver that California is seeking.
Yeah, so California, Governor Brown last week signed SB 10, which would authorize Covered California, our state marketplace, to seek a 1332 waiver to allow undocumented immigrants to be able to buy into Covered California. This is without subsidies, so it's not. It's a fairly modest change. It simply says that right now these folks are excluded from coverage. From even entering into the marketplace. This allows Covered California to offer non-QHP products that would mirror what's in the exchange, and so people would be able to use that portal regardless of their immigration status. It's given how restrictive the Obama administration's guidance was on 1332 waivers. This will be I think an earlier Health Wonk review had a comment of given how restrictive it is, could anybody get a 1332 waiver? But this is the kind of narrow, targeted thing that possibly could make it through even the existing guidance, because it really, doesn't. It's a modest change and doesn't affect the four pillars of a 1332 waiver, which is that you must meet the same level of affordability, of coverage, of comprehensive benefits, and of deficit neutrality as the Affordable Care Act. And I think that this kind of small change meets that test.
So my memory of that earlier health affairs post was that the concern was that the standards were a little vague, the standards for review. So are you saying that you think that in this sort of narrow waiver request situation, the standards would be clear enough?
So we've spent a lot of time on this, and let's be clear: this is a totally new process for this for the federal government. A 1332 waiver, we've never done it before. Yeah. There's been a couple of states who have submitted waivers. Massachusetts, a change with some reporting requirements. Hawaii wants to adapt their decades-old prepaid care act to the Affordable Care Act. This is a different approach, which is just simply to have a relatively small change, just get a waiver of a very small provision in the overall ACA. And there is a question about how much documentation do you have to provide to the federal government to prove that you're meeting these tests. and for something that's small like this, we hope that the requirement for the documentation, the academic, the academic papers, the modeling, etc., is relatively minor because some of this is self-evident. But we'll see how that plays out. If this was a major change that would require lots of financial modeling, lots of projections of 10-year Treasury deficit models, that would be a different story, and there would be an interesting question about how much would states have to prove that they're meeting these tests in order to get the thumbs up. Now we can't hear you. Oh, there you go. Now we can't hear you. Now I can't hear you, David.
Timeline.
Oh, there you go. Okay.
Okay. Timeline. Any fearless predictions on the timeline?
Yes.
Getting the waiver request in and getting it processed?
So Covered California, at their last board meeting last week, they announced that they were developing the proposal now. They would have it out for public comment in August, and that there would be a opportunity for written comment as well as in-person comment at the August board meeting, and their goal is to submit it by Labor Day. If they do that, they have 45 days. The federal government has 45 days to determine if the application is complete, then 180 days to consider the merits of the proposal. That would allow this president and this administration to consider it before they leave town.
Great. And do you have a sense or a range of sort of numbers of people who would be affected by this, who would have the marketplace open to them as a result?
So, as I said in my post, this isn't the revolution. There will still be significant affordability barriers for people because of what we're not proposing here is to provide subsidies to undocumented Californians. That's a fight for another day. I think the issue here is, however, even if this helps in the margins, helps a handful of families be able to buy coverage together. In California, a small percentage is still tens of thousands of people. And so, our projection is something like 50,000 folks would use this. Again, one of our key factors here is that over 70% of undocumented residents in California are in families with a mixed immigration status, where there's some members who are legally present and others who are undocumented. And so this allows the family to buy coverage together, even if some will be subsidized and others are not.
Got it. Great. Okay. Progress it is. Thank you for that update. So, Jan, you had written this week about Theranos, and wonder if you'd like to jump in here and give us your take.
I did hear what Anthony had to say. Very interesting. Before we go to Theranos, as a doc, this is really a no-brainer. I mean, one way or another, the health care for persons with undocumented status who are residing in the United States will get paid for one way or another. It's a question of bringing them out of the margins of society. However, that being said, this is really not a small change. I think it would be a watershed change in the first time that federal dollars, which are pulled collectively from across the United States, are going toward the care of individuals in a context that has very strong political narrative. There's that musket on the wall behind me. That represents you could think of that as representing a mindset of individuals that would be very troubled by a major policy shift in how we handle this. I think it's going to be very interesting to see how the administration responds to this. Anthony, I think my question to you would it be politically wise or smart, for folks to want to wait till after the elections are over to put a stake in the ground to avoid, the kind of political volatility and combustibility that a topic
I want to
like
be
this
clear
would bring
that the proposal that is being contemplated and being submitted to the federal government does not involve federal dollars. I want to be very clear about that. This is about opening up the marketplace. And one of the reasons why we think that this is more doable now is that, this is the first year that Covered California is entirely self-sustaining, is getting no federal dollars even for its own operations. And so to the extent that there was a policy justification for this ban in previous years when this was when the operations of Covered California was subsidized, now that's not the case. This is an entirely California state-operated, self-sustaining entity, and so it should be able to operate under California law. But we do think the principle of inclusion is really important, and so that's why we do think it will be watershed, even if it does not have those affordability subsidies available. With regard to the timing, because it doesn't involve any federal dollars, I think that this is a moment where, California's politics with regard to immigration is different than the nation's, but I would say that this is a moment where folks can lean in and say, if I believe that there are folks who are on both sides of the immigration debate, whatever you believe in with regard to immigration policy, we all have an interest in getting more people connected with coverage, especially if they're using their own money. If the folks who are against immigration because of concerns of drain on public resources, this is not about that. And so if it would be interesting to see what is the debate about this. If it's not about public charge, is it really just about excluding some category of individuals? And I think that's not necessarily a bad debate to have in an election time. I would also point out that in California, this actually got a 2/3 vote in the legislature, including multiple Republican votes on both the Assembly and the Senate. We had unanimous Democratic support, but we did get bipartisan support in both houses, multiple votes. So that's our thinking on that.
Great, thank you.
Turning to Theranos, I have a weak spot for underdogs, and what does it provide? Succor to the underdogs and pain to persons in position of power. I mean, Theranos has undergone a remarkable transition from being, a darling of direct-to-consumer laboratory testing to an entity that's been really beat up, and some could argue appropriately, by numerous regulatory agencies and probably the investors that have been backing the company. That being said, the ultimate value proposition is very interesting, and that is completely bypassing the insurance-dominated fee schedules, pricing a product that is that's directly linked to consumer notions of value, allowing persons to pay out of pocket, and they're not really paying for a lab test, no more than as a Kodak customer I paid for film. As a Kodak customer, I paid for memories, and I think that what people are buying in today's health marketplace, interested in buying, is insight and knowledge about their health status, and blood tests are just one way to do that. And if Theranos can do that, can tell me whether or not I've got hepatitis C for $8 and allow me to manage that. I don't know what the fee is, but you get the idea. Then that I think that genie is out of the bottle. I think Theranos stumbled in the execution, but the underlying strategy still is very, very significant, and I think this is going to be an area that
I think I would agree
continue to keep an
general
eye on
that
as wonkers.
This is an important sort of inflection point in terms of a direct-to-consumer model for this sort of service, and I would agree with what you said, that it's more about the broader set of information and services rather than the individual blood test. And we've sort of been moving in that direction with some of the direct-to-consumer sequencing services, where we're not doing the full sequencing as was described in the first post we discussed, but the sort of narrower bits of sequencing that are maybe of greater interest to individuals, and tie in with other things that are sort of beyond healthcare to genealogies and other things like that. I guess the issue with Theranos is really sort of what seems to be turning out to be the overpromise and the overreach here. And I guess the question is whether this company will have a piece of the pie as it exists in the future, or whether they've just sort of missed their chance entirely.
I agree. They built everything on a technology, a chip, apparently, that we still, as outsiders, cannot really assess, and I think that's part of the problem. My advice to Theranos would be to not only re-examine the value proposition and how to deliver that to the consumers, but start really working on committing, and I call it tithing, at least 10% of your budget, overall budget, to research and development, and doing it in a public forum, a peer review literature, so that folks like us doctors and folks like you who are really smart on policy are able to correctly ascertain and get a better handle on just what
would you recommend that tithing to any
what the
company
value
in
of the services
healthcare,
are.
or do you think that's sort of a corrective penance that's needed here?
I think healthcare is I personally believe that healthcare is different than any other industry. And while a lot of other industries do research and development, I somewhat religiously, follow the idea that up to 10%, and we're talking about the top 10%, the top, the best and the brightest resources should really go toward advancing medical knowledge for the betterment of mankind. And while you're at it, showing that you've got a better mousetrap and you're better able to deliver a service than other persons competing in the peer review literature, I think is a good way to, from a policy perspective, to make sure that people are getting their money's worth. It's underwriters lab on steroids.
Another post I'd like to sort of bring into the discussion is Roy Pose's post on clinical practice guidelines. And he raises the question of conflicts of interest around the development of clinical practice guidelines and their adoption. And sort of how can we improve guideline trustworthiness by calling out or eliminating conflicts of interest. And this was something that was brought up in a publication and of the Institute of Medicine, and recently some guidelines have been looked at and sort of measured against those guidelines, and said, do we really get to have we reached this level? Have we avoided conflict of interest? And I think the short answer seems to be, we may have a framework in place, but we have a long way to go before we reach that point. And where so many standards and measures and so forth are tied to compliance with guidelines in practice, I think this should be a wake-up call for folks way beyond the narrow professional societies where these are being developed, because it affects really everyone in the healthcare economy.
I agree. Anthony, I'm going to go first, and then I'm going to mute myself to hear what you have to say. And if I keep looking off to the side, it's because I have two computers going here. But if you believe guidelines are an important answer toward healthcare reform, then it's absolutely incumbent, I agree, to to not only meet the principle that they be free of conflicts of interest, but to also avoid the appearance of conflicts of interest, so that docs, everywhere, and all healthcare providers can be confident that they really do represent pristine standards of care, the pristine approaches to care, and not, an underhanded attempt to promote the use of a particular device or a particular drug. I personally, as a practicing physician, and I know many of my colleagues feel this way, place guidelines, as something that's important, but not critically that important. We follow other principles in determining what's best for our patients: shared decision making, standards of care. Local community standards are very important, for example, and that may be a topic for a whole other post. In addition to that, if you are an expert in the field in the approach to care for a particular condition, it's very, very difficult to not bump into manufacturers, device manufacturers, big pharma, in helping them fulfill their mission and their value proposition many times. And when you do that, it's very, very easy to get the taint of developing a conflict of interest. So I feel for these guys, and I think it's a lot harder than it looks. But when Roy outlines all the places where it's fallen down, I'm personally very, very troubled
Anthony,
by this.
Please feel free to jump in.
Yeah, I mean, I agree with what was stated. It's the patient's trust here. I mean, speaking not as a doctor, but on the patient side, it's really critical that people have trust in the advice that they get, and if they feel like that trust is being influenced by a variety of factors, that's a concern. That was the reason why there was the backlash against managed care several years ago. That's you could have some promising changes, reforms be undermined by having that lack of trust. And I do think that whether it's on the prescription drug side or medical devices or other pieces, that there is concern, and there's reason for concern. There is lots of evidence that some of these relationships have led to inflationary spending in our healthcare system, and so we need to figure out a way that provides some appropriate guidance while not restricting the natural discussion of ideas and of different approaches between, within the clinical community. And so that's, it's something that needs to have a lot more focus on. And, we've been looking at it a lot on the prescription drug side, but it's not just that. It's with regard to all the different interrelationships within the medical field.
Yeah. I think I would tie this discussion to Jason Shaffrin's post, A Patient Perspective on Cancer Care Funding, which really highlights the need to bridge between sort of clinical truths insofar as we can know them and patient preferences and desires. And I think it's important to note, as Jason did, that there is sometimes value in dealing with patient needs and desires that are not necessarily strictly driven by clinical truths insofar as we may know them.
What a great post that was. The thing he pointed out that resonated with me was the observation among many patients that hope, that even if the odds are very, very low, even if the likelihood of achieving a remission or a cure can be distant, hope from their perspective is very, very medically necessary. And when I say medically necessary, I mean that in the pure insurance term, because medical necessity is a big deal, and it's hard to reconcile standard notions of medical necessity in a regulatory context with the patient desire, to keep hope on the table as part of their medical care. It's that, that's a very, very thorny issue, and Jason did a great job of discussing
it. I think we're coming to the end of our time today, and I thank you both for dipping in and dipping a toe in and joining me here today. I'm sorry about the technical difficulties. That seems to be rite of passage with a platform in beta here, as Blab is. But thanks for your patience, and thank you, everyone, for your patience in dealing with our technical issues.
Pleasure to meet you all electronically.
And
yes,
Anthony,
it's always
thank you so much for
to have
joining us.
some of this
It's nice to finally meet you.
Or almost face-to-face interaction. You certainly see the face, hear the voice. It's a lot different than just reading the blog posts. If it were only about reading the blog posts, that would be great. But this is an extra benefit, and we enjoy that. Well, thank you both.
Thank you.
We're coming to the end of our Health Wonk Review on Air number 6, and we look forward to the next one. We'll do another one in 2 weeks, and then we'll go to the Wonk summer schedule of monthly as opposed to biweekly. And then we'll be back full force in the fall, in the final sprint to Election Day. Thank you again.
Thank you.
Bye-bye.
Thank you.